degree, then there will be cut effect. And if it is enormously high, like 200 to 500 degree, then there is a tissue evaporation. And different tissues have different resistance. Blood has least resistance, while the fat has the highest resistance. So when the resistance is more, so if you give the same current to this different tissue, probably the heat generation is maximum where there is highest resistance. We also know that in electrical surgery, we use something through the endoscope, but we have a patient plate. And this is to complete the circuit. And remember, at every stage, the current is the same, but where the instrument is, the point of the point which touches the tissue is less, therefore the current density is higher. At the patient plate, because the patient plate is bigger, the current density is low, and that's why you have no tissue injury or less tissue injury if the patient plate is not properly fixed. So basically, you do it to complete the current. In monopolar and bipolar, the difference is in monopolar current, from the electrosurgical unit, the current goes and then the current comes back through the patient plate. While in case of bipolar current, there is no patient plate. You don't need patient plate, because the current goes from the electrical unit, electrosurgical unit, and then goes to the whatever is the instrument you are using, and that is bipolar current instrument, and there is a complete circuit which is going back from the same instrument. So basically, as I told you, when the tissue is rapidly heated beyond 100 degree, there is cutting effect. And there are different types of cuts. Prakash, can you tell us what different types of cuts are these? Auto cut, dry cut, endo cut, IQ. So can you just elaborate on that?
Yeah, before that, Nilay, regarding the completion of the circuit, as you mentioned, in the monopolar, that pad which you use, that is also very important, and we should remember about that, because that has to be a large one and it has to be kept our not on bony surface. It has to be on the muscle, and there should not be any hair, because that's all something very important. And also another thing, you would also agree that before we subject a patient for electrocautery procedures, we should also inquire whether they have got an implantable device, especially any permanent pacemakers or defibrillators, so that should also be kept in mind. All the modes needs to be changed prior to this thing. So that was just something which I added. So there, see, as you have already.
So just a minute, since we've taken this pad thing, let's complete it. You said it should not be over the bony area, and it should not be over the implants also, right?
Yeah, that's right. Yeah. So
and
should be
what about the metal jewelry?
Yeah, that also is something which can cause problems. So if it can be covered, or it can be if it can be removed, that is the best. If that is not at all possible, then we might have to cover it up.
Yeah, it's for bipolar current is fine, but for monopolar current, because it will travel through all these routes, we should take care of it. And always, as Prakash said, always inquire about the pacemaker and always contact the pacemaker company, because they will come and change the mode. Without that, if you use, there will be a pacemaker malfunction and you can have problems during the procedure. Yeah.
So the thing is that between the conventional one is that the traditional electrosurgical generators, they provide only constant wattage, and that will not be enough for all these procedures like ESDs and POEM. So for which the high performance computerized ESG is required, which provides a modulated current options. So as you said, there are different types of cutting and coagulating. So the thing is that this combines some amount of cutting as well as coagulation. So there are certain cut modes where the cutting aspect is more and coagulation is less. And there are coagulation modes where the coagulation aspect is much more and the cutting aspect is less. So the cutting modes which are available, depending on the machinery which you have, there will be some changes in the name, especially for the cut mode. So for example, the RB has got endocut, I, endocut Q, then it has got an autocut and tricut. So while the Olympus, the endocut I, they have named it as pulse cut slow, and endocut Q is a pulse cut fast, and autocut is pure cut, and tricut is blend cut. But while with regard to coagulation modes, the other modes which are available are soft coagulation, forced coagulation, swift, and spray coagulation. So again, most of these names are similar in Olympus except the swift coagulation, which they have named as power coagulation. So in the coagulation modes, if you see, the soft coagulation has got a superficial kind of coagulation setting with a slow coagulation. So while it is with about the peak voltage being about less than 200. So the most superficial one is the soft coagulation. The next one is the forced coagulation, where the peak voltage is about 800 to 1800. The speed is it is more faster coagulation than the soft coagulation. And then is the swift coagulation, where the peak voltage is more, around 600 to 2500. And it also gives a faster coagulation.
Yeah. I agree. I just have to add on to one that soft coagulation is very pinpoint. It doesn't spread so much, and that's why it is used for vessel, because it's pinpoint. It's, as you said, it's a gentle coagulation. There is no carbonization. There is we use it for vessel coagulation. So normally, Prakash, when you are using soft coagulation, so what are your settings?
My usual soft coagulation setting is around 50. The effect 5, that is what which I use.
Yeah, so same here, but anything between 40 to 50 volts with effect 4 or 5. What are these effects we are going to discuss later? When would you use spray current? And we know that spray current is very powerful current. So when would you use spray current?
Yeah, so the spray coagulation, as you said, it has got a much higher voltage, peak voltage, and it can produce current. So it can be used while in tunneling, you can use it. Even for myotomy, you can use it. So even dissection, some people use, but I don't use it for dissection. Earlier I used for tunneling, but now I use forced coagulation.
Yeah. So the spray current is a non-contact current. When you use it for tunneling, it's very fast because you just have to spray the current, and because it's very powerful current, it will just burn the tissue. Only thing is, I always worry that it also not damages, but it will have effect on the surrounding tissue like heart and other things. And that's why, as Prakash has said, we also shifted from spray to forced current for tunneling. Only difference when you are using spray current for tunneling and when you are using spray current for myotomy is when you are using spray current for tunneling, you don't touch the loose areolar tissue. But when you are using it for myotomy, you have to touch even if you are using spray, isn't it, Prakash?
That's right.
Yeah. Otherwise, I use a lot of swift current for ESD. Because it's a very fast coagulation with hemostasis. At the same time, it is not very powerful as spray current. So there is not so much of tissue coagulation. In fact, swift has good hemostasis along with effective and fast coagulation. So I Now I've shifted for my ESD. I used to do ESD with endocut I for incision and endocut Q for dissection. But nowadays, if I'm doing ESD, I use more of dry cut for making an incision, and sweep coagulation for dissection. So can we talk something about this cut current, Prakash? And I wish anybody else has joined, because I can't on screen. Prakash, you would be able to see. Has Truptesh joined? Has Krish Raghunath joined the thing or not?
I think,
I
yeah.
Hi, Nilay.
No,
Hi Truptesh, hi. So Truptesh, welcome
Prakash.
to the meeting. Can you share your views on cut current? Where you would use? What are the different cut current? Can you just share your views on that?
So just the basic polypectomies, especially in the right colon polyps or any transverse colon polyps, we normally use the cut current compared to the coag, which is mostly used like a blended one in the sigmoid area where it's more pedunculated polyps, just to give more coag and then the cut profile. And when it comes to the Zankers, it has its own settings, but it's more like the cut. And then when we use the Axios as well, it has the 205 of coag. So that's a blend of current that we use. And again, for POM and ESDs, it has its own blend where it's sometimes being used as spray and sometimes forced, depending on how, if we see a vessel. But that's the blend that we have been using all the time. But one thing that I would like to press on is the auto, that when they start coming out with a dry cut. So that was one thing which came out when POM was initially introduced. That dry cut was something that they used to press on more, and the RB guys at our place used to talk about it. And it picked up a little bit in the beginning, but then eventually people used to do it more customized as they start doing POM on their own.
Yeah, so we would be talking on individual procedures current, but just I wanted to say what is the difference between different current. So we used to use pure cut, and that is auto cut. And as you rightly said, we use it for cystotome puncture. We use it for very minor papillotomy or a pre-cut, or when you want to use the lumen opposing stent. Dry cut, as I told you, I use it for initial incision of ESD. When you make a circumferential incision, I always now use not endocut I, but dry cut, because it has a good cut with coagulation. So when you are cutting, many a times we've seen when we used to do it with endocut I, they used to bleed. With dry cut, that problem is much less. The endocut I, we use it for papillotomy, for even needle knife, and of course for POEM incision, you can use either endocut I or endocut Q. So what is the difference between endocut I and endocut Q? We'll discuss later. Most of the times we use endocut Q either for polypectomy or POEM incision or ESD. But as discussed earlier, we have shifted to force, and most of the guys do it spray. Prakash, can you tell us what is this endocut IQ and this smart current modes? When we say this is effect, this is cutting duration, and this is the cutting interval. Can you just share your views on that?
So the endocut I and endocut Q. So both the endocuts, they have got an interval between the cut. So this is the time where the coagulation cycle happen. So in the endocut I, the initial cutting has got a short coagulation with the incision. And then after that, there is between the two cycles, there is the coagulation. So in the endocut Q, that in initial incision point, that is slightly more than the endocut I. So that is the difference between these two.
And that is the technical jargon.
Yeah.
But for the cutting effect, what exactly is I mean and Q mean?
Is the incision. Yeah. So that is what we use for.
Yeah. So and when I say, okay, this is effect 2, cutting duration 3, cutting interval 3. So can you just tell us what exactly is this?
The cutting interval is how short or how long is the cut. So if the interval is short, then you have got a more rapid cut. If it is a long interval, then you have got a slower and more controlled cut. So if the cutting duration, it is equivalent to the length of the incision. So if the duration is short, you have got more cutting cycles are necessary. But if it is the cutting duration is long, then the less cycles. So it's a longest cut. So that is the interval and duration.
Yeah. So excellent, Prakash. And I just want to add one. One is effect. Effect means intensity of coagulation. So suppose my effect is 1 or effect is 4. So in effect 1, coagulation will be less, or
So
there will be none. In effect 4, there will be more coagulation. So in this graph, you can easily see in effect 1, there is no coagulation at all. Only cut, cut, cut. In effect 4, there is more coagulation. So there is cut and there is coagulation. So all these smart current, they are combination of cut and coagulation. And in duration, in cutting interval, when I say cutting interval 5 or 6, means cut remains the same between 1, 2, 3, 4, 5, 6, but the coagulation goes up. So you have one cut, and then if the interval is more, then the coagulation interval is more. So there will be coagulation for more time. Why it is important? Like when we do say polypectomy, we use effect 2, probably duration 3, but cutting, or duration 2, but cutting interval has to be 5 or 6, so that you have more coagulation for longer time, and therefore they don't have bleeding during polypectomy. Yes, Prakash, you were saying something.
Yeah, that's it. So when the effect comes down, there is almost practically nil coagulation. So effect 1, it's purely a cut sort of electrocautery which you have.
So that brings to Truptesh, different, you said, different current what you use. So at your center for POEM, what settings do you use? And also I would like to have feedback from Prakash.
So the settings at our center, and also what I've been taught with Dr. Greg Haber, the settings that we used to use is endocut Q, force coag as well. So the one that you're shown in the lower frame with the effect of 2, 3, and 4, ours was effect of 2, cut duration of 3, and maybe cut interval depending on the type of, if it's bleeding more, then maybe just go to 3, try to manipulate as each and every case comes across. Force coagulation, same settings. And then we also had a coag grasper setting accordingly if it's a bigger vessel for POEM or any big polyp. So,
and Prakash?
So again, for POEM, for the mucous incision, it's endocut. Again, the effect for POEM, the mucous incision, it's endocut. Again, the effect for POEM, the mucous incision, it's endocut.
Hello.
Yeah.
Hello.
There's some issue with this.
The same voice is coming back and back. Yeah. So now, but it's okay. Please go ahead.
Yeah, you need to mute your platform if it is running simultaneously. Hello.
Yeah. So basically, Prakash, as you told us, hello.
Yeah.
You told us before that now you use force coag. So in force coag, we use effect 2, and
Yeah.
maximum votes either 50 or 60, not more beyond 60. Usually I keep 50, and
Right.
that is for submucosal tunneling. For incision, we use endocut Q 234 or 233. I believe that many people use spray coag, where the incision is again made either by endocut I or endocut Q. But the difference is for making the submucosal tunnel and myotomy. For submucosal tunneling, when you are using spray coag, it has to be effect 1 or maximum effect 2 with maximum votes 50. And when you are doing myotomy, you can do either endocut I or spray coag or endocut Q. We prefer a force coag and endocut Q. This is my setting, which we usually use. And as Kruptes has said, if there is a bleeding vessel, we use soft coag, and that is effect 4 or 5 and 80 to 100 votes. Yeah, anybody wants to add on to it?
Yeah, our setting also seems to be very similar to what you said.
I think Chris is online as well.
Yeah, Chris, welcome. I'm Niloy, and we were discussing electrosurgical units and different modes and different procedures, what modes we would be using. So would you please enlighten us if you are using knives, normal knives, Olympus knives, not the Orbe one, what modes we would be using? So would you please enlighten us
I'm
if you are
hearing
using
knives, normal knives, Olympus
echo
knives, is coming
not the
through here.
Orbe. Yeah, are you on the platform? You just have to cut that platform and just be on this Zoom attendee link.
Echo is coming through here.
Yeah, are you on the platform? You just have to cut that platform and just be on this Zoom attendee link.
Okay, I'll do that. I'll do that now. 1 second.
Yeah, are you on the platform? You just have to cut that platform and just be on.
Yeah, right. I've done that. Yeah,
Great.
Thanks for that. Sorry, I got a bit of a trouble trying to get into this session. Thanks. I just picked up the last few minutes what you all have been talking about. So I agree with what you're saying with regards to the dry cut and the different settings. So here I've been using the 300D and I've been using the endocut for the incision, and after that for the tunneling, the spray coagulation is more what I intend to use. And for the myotomy, I tend to use a swift coagulation because for spray coagulation, I think it should not touch anything. That's how it works. Otherwise, it can cause a lot of damage. So I tend to use spray only for the tunneling and then use a swift for cutting.
Yeah, actually, that's what my worry was when I used to use spray current. Now we have shifted to force current for submucosal tunneling and endocut Q for myotomy. I think the myotomy is much sharper with endocut than the coagulation current. I don't like my muscle to look black.
Yeah. I think that's something which recently I was speaking to the other day, and I think he is also using the endocut, and then because there's lots of bleeding as well, uses now and then coagulation. So I think a combination of that should be fine.
Yeah, and so the other method we use it when we are nearing the G junction. We know that there are vessels even beneath the muscle. So the first cut we use it coagulation, and then the rest like first coag and then the rest the endocut.
Yeah, I think that's the sort of a technique what many people are doing as far as I know in the last year or so. And these things, as you know, have been evolving over the years when how it was started and what settings they were used, and we keep learning. Almost on every meeting, people share their experience here.
And what about ESD? What currents do you use for making an incision and also for dissection?
No, I used to, because I stopped doing ESD here when I came to Australia because a couple of my other colleagues have been doing quite a few. So I'm not doing ESDs now. But when I used to do ESDs, I used to be using, forced coagulation or soft coagulation for the bleeders, and forced coagulation I was using.
Prakash, what currents do you use?
So for the incision, I use a dry cut, and for dissection, I use swift coagulation or forced coagulation.
Yeah, so that's what we nowadays use. As I told you, I used to use EndoCut Q for everything, for making an incision and then for the dissection. But now I've shifted to dry cut for making an incision. And I told you the reason, because dry cut has a very good coagulation property. So while making an incision, bleeding is not too much. And for dissection, now we have shifted to sweep coag because it's a very good, clean coagulation current. Only thing you have to, depending on what knife we are using and what sort of RB or whatever electrosurgical unit you are using, you should know your settings. So suppose I'm using a dual knife, my settings would be lower for dry cut. That would be effect 2 or 3 30 volts for making an incision, and for dissection sweep coag 30 40. So I remember always 44 and 33. That is what I remember, because it's very difficult to remember the current setting every time. So 33 for dry, 40 for sweep. But if you are using IT knife, you need a higher current. So there, as I told you, for dual knife, it is 33. Here it is 54 and 54 for both incision and dissection, because IT needs a little bit higher current than dual knife. Dual knife, if you see, the tip is very tiny. And if you try to give very high current, it will work, but then there will be a lot of coagulation, number one. And second one, you will lose knife in one procedure. So like you may require 2 knives in one procedure if it's a big lesion. So that's why the current has to be kept a little bit lower for dual knife. Anything to be added, Truptesh? Do you want to add on to it?
No, I think that's what is quite appropriate what they're saying. So I don't think there's anything more I need to add to it.
Nilay sir?
Yeah, please.
Yeah, we need to shift to the main session now.
Okay, so I think we are almost done. Thanks all my co-panelists, Truptesh, Krish, and Prakash, for sharing your expertise and views. And we'll end this session. Thank you all.
Thank you, Nilay.
Thanks, Nilay. Can I ask you, should I wait in this or should I log back into the other one?
I think you should be fine if you are here and if you are getting the main auditorium link. Otherwise, just shift. Yeah.
Yeah, you can shift to the main auditorium link, sir. We are closing this links now.
Okay, thank you.
Okay.
This is only for the meeting rooms. Yes.
Okay.
Adish, please stop the streaming.